Hello, I'm Erin Hartnett. I'm the Program Director for NYU College of Nursing's Oral Health Programs. I'm also a pediatric nurse practitioner at NYU Hassenfeld Center for Children with Cancer and Blood Disorders, where I work in pediatric neuro-oncology. In addition to caring for children who are currently being treated for brain tumors, I also coordinated the Late Effects Program for pediatric brain tumor survivors and the Pediatric Dental Residency Program in oncology. And it was working with these pediatric dental residents that I became aware of both the acute and late effects that cancer treatment was having on the children's teeth. And I decided that it was important for us to do something about this upfront to prevent some of these problems. So I'd like to share those with you. In the year 2000, the Surgeon General's report, Oral Health in America, declared that dental caries in children was a serious problem. He called it a silent epidemic, the most prevalent infectious disease of childhood, 5 times more common in asthma, and very common in poor and minorities. And he asked for the medical community to become involved in oral health, awareness, and prevention of oral health disease. The American Academy of Pediatrics, the American Academy of Pediatric Dentistry, took these ideas very seriously. And they set up all of these policies which were designed to make it possible that for children who were seeing their medical providers, because children see their medical providers 13 times in the first 36 months, that when they're seeing their medical providers for routine medical checkups, they could receive oral assessment, prevention services like fluoride varnish, and referral to a dental home. These policies were designed to increase the knowledge of primary care providers, to increase their practice behavior, and decrease barriers to dental care. So they defined a dental home, they developed risk assessments, they did guidelines on topical fluoride, they had interventions for pediatricians, guidelines for oncology. And then by the year 2009, both Medicaid and SHIP were providing reimbursement for primary care providers doing oral assessment and fluoride varnish. So where do caries come from? This is an infectious disease. It's caused by a bacteria. The bacteria is strep mutans. How is it transmitted to the child? From the mother or primary caregiver. And the way it gets there is through food sharing or utensil sharing. So it's very important to let the primary care providers know about this, so they won't be licking the pacifier, so they won't be tasting the baby's food or sharing their foods and drinks with their children. In addition to the bacteria also needs carbohydrates. And it's through frequent ingestion of carbohydrates that the bacteria is metabolizing the carbohydrates and producing a very strong acid in the mouth, and that acid breaks down the enamel of the teeth. And if you have a child who's having frequent sugary snacks, frequent sippy cups and juices, they will be constantly having this danger zone of acid because they'll be having this sugar broken down, creating this acid. And the acid takes 20 to 40 minutes to get out of the mouth, and by the time that happens, they're having another snack. So they're constantly having this environment that's producing caries. And this is important for the oncology patient because we do tell them to have frequent snacks because they often can't tolerate foods as well. So this is an issue that we need to address with oncology patients. They're also at a high risk because they're overburdened with medical appointments. They don't see dental care as a priority. The families have enough to do trying to get their medical care. This is an infectious disease and the children are immunocompromised. They also have impaired saliva, poor nutrition, and as I just mentioned, the frequent feedings. The most frequent source of sepsis in an immunocompromised patient is the mouth. 90% of cancer patients develop an oral problem. And anywhere from 30 to 95% of pediatric cancer survivors have some sort of dental abnormality, mainly because if they've had chemo before age 5, the roots have not been fully formed on their teeth, and they can have very short roots, which cause many problems throughout their life. But because of the separation in our healthcare system between medicine and dentistry, often the oncologists are not aware of the problems. So imagine pediatric oncology patients with dental caries. They don't have enough problems without getting a toothache, something that could be prevented. Now, as oncology providers, we are very good at looking for mucositis, xerostomia, fungal infections, gingival bleeding, but we often ignore the teeth. And dental caries can cause pain, poor nutrition, difficulty chewing, poor weight gain, missed school, impaired language, reduced self-esteem, cellulitis, sepsis. But think about how much more serious any of these are in a pediatric cancer patient, with more pain, more poor nutrition, with vomiting, with lack of appetite, missing more school. And what if it does become cellulitis or sepsis and cause treatment delay? So these are all serious problems that can easily be prevented. And so in my next module, I'll explain to you how we are preventing caries at NYU Hassenfeld Center and how you can do this too.